Hello, everyone. And welcome. Thank you, everyone, for joining us today for Angel Foundation's Understanding Our Experiences Forum. I'm Dave Becker, President and CEO of Angel Foundation. Today, we have close to 300 attendees that have registered for this conversation. That tells me there's a great need for this discussion. Thank you for being here for this important conversation. Every day, we work with individuals that are challenged by the dreaded disease of cancer, and we are fortunate to be a part of our cancer community. For those of you who may not know Angel Foundation, we are a nonprofit based here in the Twin Cities that is dedicated to helping adults and their families through their cancer journey. We help those facing cancer through financial assistance, grants, for basic needs, as well as providing education and emotional support to the entire family. Since our inception 20 years ago, we have given out more than $10 million in financial assistance, and we have helped more than 30,000 individuals. However, our work is not done. People need our help more than ever before, and we are ready to do just that. We see the struggles that cancer patients face. We know the hardship this disease creates, and we are determined to help provide support to those impacted. We know cancer disproportionately impacts Black, Indigenous, and people of color in many ways. As a leader in the cancer community, we see the burden cancer delivers, but we are aware we do not understand every person's experience. Our hope is to gain understanding how different factors significantly contribute to healthcare disparities and identify strategies to minimize or eliminate their effects on health. This forum is meant to be an introduction to the work we are setting out to do. We need many voices and experiences at our table to help those facing health equity challenges, and we are committed to being the convener to move this issue forward. We are not experts on these experiences, and that is why we have this robust panel of individuals to help lead the discussion. We are also very fortunate to have Jackie Thomas Hall moderating today's forum. Jackie is an Angel Foundation board member and is the Vice President and Chief Diversity, Equity, and Inclusion Officer at Allina Health. In addition to being a seasoned diversity and inclusion leader and consultant. Welcome, Jackie.
Good morning or good afternoon. How's everyone? I am having some technical difficulties, so excuse me. All right, sorry about that. Welcome. We are thrilled to have everyone tuning in today. We had a great response to this forum and equally have a wonderful panel who represents a wide variety of experiences working with and in the cancer community. Our goal today for this event is to start an important discussion that will lead us to strategy for our cancer community, a plan that we all can take part in to help those when they hear the dreaded words, "You have cancer." It is important to have a variety of experiences and voices to sit at the table with Angel Foundation to help build bold actions to make a difference. It's critical that we need to understand the challenges that individuals face, and we wanted to start with conversations by hearing directly from leaders in our community. Now, before diving into our discussion, I want to first introduce Emma Connell, Research Associate, Wilder Research at the Wilder Foundation. Emma led a recent evaluation of 2,200 Angel Foundation clients, and we would like her to highlight these findings. Welcome, Emma.
Thanks so much, Jackie. I'll share some slides here. Share my screen. Great. So I will just take a few minutes to share some of what we found in our recent survey of Angel Foundation participants, just to lay a little bit of the groundwork, some data to inform the conversation that's going on, and perhaps answer a few questions about who Angel Foundation is serving. So, a little background about this survey. Angel Foundation was interested in better understanding the needs of their BIPOC, that is Black, Indigenous, and people of color clients, as well as those clients' experiences with the Angel Foundation. And in particular, they were interested in learning more about inequities that these clients face. So we collaborated to create a survey of Angel Foundation clients to ask about their access to basic needs, as well as their experiences with Angel Foundation. And we heard from a lot of participants. We got a 30% response rate, which is just incredible. And actually, of those who responded to our survey, 40% of respondents identified as BIPOC. Really incredible response. So I feel really great about what we were able to learn from this survey. And I'll also note that it's just really important to collect this kind of data to steer decision-making at the organizational level. Surveys like this allow you to hear the perspectives of a large number of clients, people affected by an issue, et cetera. And by doing that, individual decision makers or groups of decision makers are able to check their own assumptions and make decisions grounded in what those they're serving have indicated that they truly need. So I'm really glad that Angel Foundation did this work to ensure they're moving forward in a way that's informed by the opinions and the realities of the people that they serve. So I'll just leave you with three major things that we learned from this survey. First of all, we learned that of the basic needs we asked about, medical bills and healthy foods were the hardest things for Angel Foundation participants to afford. These were the areas where over a third of respondents indicated that they always or often struggle to afford these things. It's also notable that this was far more pronounced for BIPOC respondents than white respondents. You can see the different proportions of respondents who indicated that they always or often struggle to afford these things. But that wasn't it in terms of disparities. We actually saw that for every single basic need we asked about, BIPOC respondents reported that they were always or often struggling to afford these more than their white counterparts. So the disparities are pervasive and they exist in terms of, clients being able to afford what their families really need. We've included a few examples here so you can see the disparities between BIPOC clients and Caucasian clients and what they're able to afford. Third, we learned that the COVID pandemic has made it harder for Angel Foundation clients to be able to afford what they need. It really exacerbated existing disparities between white and BIPOC communities and their ability to afford these things. So while 74% of white respondents said that the pandemic made it harder for them to afford basic needs for their family, 91% of BIPOC respondents reported it had done so. So our findings support the understanding that while all cancer patients face serious financial challenges, cancer patients who identify as BIPOC more commonly face financial challenges in affording what their families need. And that's only gotten worse during the last year and a few months because of the COVID pandemic. So all I wanted to share with you, want to leave a lot of time for our panelists to really dive into these questions. I can't wait to hear what they have to say. If anyone has questions, feel free to reach out to me. My email address is on the screen, but I'll leave it for now. Thanks so much.
Jackie, you're on mute, just so you know.
Is that better? Can you hear me? Okay, sorry about that. Thank you, Emma. The need for continued and evolved support is clear, and we appreciate your expertise and guidance. Now, we're all here today because we care. We care about those impacted by cancer, and we want to help provide hope, support, and create change for those impacted by health equity challenges. At this time, I am pleased to introduce our esteemed panelists to talk about social determinants of health and health equity. Anthony Bass is the Senior Executive Director of Minnesota at American Cancer Society. Previously working at Greater Twin Cities United Way, he is also an active teacher and pastor in the Twin Cities communities and a former Minnesota Viking. He is passionate about building a fostering community and addressing the challenges our communities face. Bukata Hayes is the Vice President of Racial and Health Equity at Blue Cross and Blue Shield of Minnesota. Prior, he was the Executive Director at Greater Mankato Diversity Council and is co-author of Right, W-R-I-T-E on Race, to be Right, R-I-G-H-T on Race, as well as co-host of a radio show and podcast called DE&I, Engaged Exchanges, which discusses issues with diversity, equity, and inclusion with local and statewide leaders. Cindy Kaigama is a cancer survivor and brings over 20 years of experience as a solutions-driven leader and health and human services professional. Founder of Healing Virtue LLC, a social enterprise focused on improving health outcomes and reducing chronic disease. She is a champion of health equity and executes policy and system changes to offer everyone a fair chance to attain their highest level of health. Cindy serves on the African Immigrant Memory Loss Advisory Board and Minnesota Diverse Elders Advisory Committee. Nora Nashawaty is a genetic counselor at Minnesota Oncology. She is passionate about patient access and equity to genetic services, as well as justice and inclusion in her field and across medicine. Nora serves in Muslim American Society and with the Minnesota chapter of American Muslims for Palestine, hoping to build a just and equitable local community. And last and certainly not least, Dr. Neel Trivedi is a medical oncologist, hematologist at Abbott Northwestern with heightened focus on colon and pancreatic cancer, gastrointestinal, neuroendocrine tumors, and quality improvement. His medical practice philosophy is to honor every patient by recognizing their individual and unique needs, as well as providing personalized care to everyone he works with. So as you can see, we have a very esteemed panel, and I can't wait for the discussion. As a reminder, due to time constraints, we are unable to offer live questions and answers during this forum. We welcome you to ask questions in the chat feature, and we will answer those questions after the forum in a follow-up email with a link to rewatch or share this recorded forum. So my first question goes to Anthony. Anthony, how is the American Cancer Society addressing health equity issues as a statewide and national NPO perspective?
Thank you, Jackie, for the question, and thank you to my esteemed panelists and the Angel Foundation for the opportunity to come and speak. First off, I'm newer to the role. I was just hired on in March, and so I'm amazed at some of the information I've been receiving and the great teammates I have working at the American Cancer Society for the state of Minnesota. And so what you may not know is that the American Cancer Society's mission is to save lives, create, celebrate lives, and to lead the world in the fight against cancer, regardless of race. Cancer is the disease that affects everyone, but it doesn't affect everyone equally. And that's important because in my previous roles, it was hard to articulate the value proposition of the organization I was working for. But when it comes to cancer, the goals are clear. Eradicate cancer. And that should be simple because it affects everybody. However, everybody doesn't have the same access to resources or support. And the ACS build this foundation of its work to ensure that everybody has an equal opportunity to a healthy life, to prevent cancer, hopefully find it early and receive high quality treatment and support when they need it. So we've made some significant progress in the fight against cancer. However, we'll acknowledge that there are significant disparities in cancer incidence and mortality rates, and they still exist throughout diverse populations. And so for ACS, we're helping to address health disparities in several ways through research. We're currently investing over $50 million in research grants focusing on cancer disparities and health equities regarding addressing disparities through prevention and partnerships. We partner with organizations like the Robert Wood Johnson Foundation to pilot community projects to explore, research, and implement community-driven solutions to address social determinants of health. And for anyone in the equity space, that should kind of interpret as those people who are closest to the work have the answers to the problems. And I'm appreciative that ACS has taken that posture. Also, addressing health disparities through access to care and early detection. We partner with the NFL to support and fund change grants at federally qualified health centers across the country to provide access to health, breast cancer screenings, timely follow-ups of abnormal mammograms, and timely access to specialty care as needed for patients who receive health care regardless of insurance. And also addressing health disparities through advocacy. The American Cancer Society Action Network, or the ACS CAN, is our advocacy affiliate, and it works with our local, state, and federal officials to secure funding for cancer research, ensuring that all Americans have access to cancer care, support public health legislation that reduces cancer risk, and improves cancer care for all Americans. Nationally, ACS CAN is working in the 12 states that have yet to expand Medicaid. And also in 2021, our goals are we're working in St. Paul to preserve funding for the SAGE screening program, which provides breast and cervical cancer screenings for low income or uninsured Minnesota women. We're also working to end the sale of all flavored tobacco products. We're also working to secure a $15 million a year new funding for tobacco prevention and treatment program, and requiring that the money prioritizes youth tobacco prevention and addresses tobacco related disparities. And so ACS, we admit, has a lot of work ahead of us, both internally and externally, but I'm happy that there are organizations here that we're following in the footsteps of, and our hope is in the future we can soon walk beside them in the equity space. Thank you. You're still muted, Jackie, just so you know.
Thank you. Sorry about that. Lots of great work, lots of focus, and appreciate the due diligence of the American Cancer Society. My next question goes to Bukata. Please share goals and strategies that have come from your personal or professional experiences with health equity.
Thank you for that, Jackie. I'll share a quick story, and this speaks to that personal experience. Happened in 1997 or 1998, finishing up my undergraduate in exercise physiology at the College of St. Scholastica, and we're going through risk factors of heart disease. And as we're going through risk factors, we talk about HDLs, we talk about sedentary lifestyle, we talk about smoking, and then just the word Black. And then sort of obesity or and other sort of risk factors. And I remember raising my hand and simply, again, this is back in 1997, 98, asking, so what do you mean by just the word Black? And at the time, the professor said, well, we see, right, that if you are Black, you are at higher risk, right, for these sort of heart incidents, and that includes high blood pressure and diabetes that contribute. And so I just remember being sort of stunned by that. And I think what we now know through a whole lot of sort of rich research is that it wasn't just being Black, right? It was that systemic racism impacted the lives of Black folks that then raised these other sort of risk factors. And so part of the goals and strategies I take from that, one is that we have to center race, in particular in the American experiment, understanding how central and intentional race was used to build the foundations and the institutions and the organizations that we all now sort of operate within, that to be unintentional or to try and provide race neutral solutions does not get us to the goal and does not get us to the sort of outcomes we want. And then the other thing I was saying is something that Anthony spoke to earlier about sort of being in community and partnering with community and those closest to the pain, being closest to sort of the power in terms of the solutions. And that was Black community, folks of color had been saying how sort of suffocating our system was, right? How suffocating race was on existence in many, many different ways. Social determinants of health are now starting to highlight that sort of that suffocating nature. And so the other sort of strategy I would take out of that is partner with community. community clearly understands how this is impacting them. And for us as organizations and institutions sort of doing this work, how are we sharing power, partnering, coming in a humble posture to community, to partner, to move forward, to figure out how we truly get to a more racially just, healthy, and equitable existence. And so I would say those are sort of the strategies and goals that come out of the personal experiences I've had, and also the professional, and actually try and make those professionally sort of salient and present as I do the work as well.
Great, thank you. You know, something you said that resonates with me is really understanding how to walk with community and understanding that we are taking their cue and their leads. We have the ability, the resources, right? But we have to really be able to understand that it's going to look different, feel different based on the community and based on the individuals that you're working with. Great, thank you. Thank you. Cindy, how has the cost of cancer impacted your experience with health equity?
Hi, everyone. Thank you so much for having me today. That's a loaded question. First hand, as person who advocated for herself with having a not being diagnosed for almost 10 years, and also a person that's experiencing real time as we speak in the last 3 weeks of a diagnosis of advanced cancer in my family. I am frustrated because I understand that not only is this a disease, it's also a business, and people profit off of the business of cancer and the cost of cancer in all forms. And if you're a person who does not have the financial access to pay for drugs or to pay for treatment, then it can easily cause a person to have a lower quality of life as they navigate through cancer. Even someone as myself who has middle class, educated, it was frustrating for me when I was finally diagnosed about 5, 6 years, actually 8 years ago. No, wait, 5 years ago. And I had health insurance, and I ended up having to have my credit became bad, unfortunately, because I had to choose between paying for treatment so that I can get the care that I need, or paying our bills. And, you know, so we wanted to make sure I stayed alive. And I had good insurance, and in real time, the insurance that the person I'm caregiving for has good insurance, but because of the cost of cancer, the lack of the transparency and also the fluidness and how business operates is frustrating when you are said that a drug costs a certain dollar amount, but then when it comes time to pay the bill, you're offered the cost, but also the drug company provides a discount for the cost of the drug. So instead of just making a drug affordable in the beginning, they charge you $10,000 to $20,000 for the drug. And if you aren't a person who is savvy enough to seek out help, or to have a care team that is able to help you to access the cost of those medications, you could lose your life. You could also go into a lot of debt for paying for the cost of healthcare. So those are opportunities as we think about the business and the cost of cancer that we can begin to explore in a different way, so that we are not causing people to die at earlier rates. Unfortunately, there are people who have higher rates of cancer, as Bukata said, because of racial and historical trauma, because of access and where they live, and social and political determinants of health, that makes it more costly for them to afford to provide for their families and take care of their homes and their children, because they have to pay for health care and pay for the cost of the medicine and the treatment. The other thing that's unfortunate is that regardless of the treatment, the health systems and the companies still get paid. So if you are getting awful care, or if you're getting great care, at the end of the day, they're still getting a paycheck. The process is still going through. They're still getting they're still getting paid for service. They're still getting paid for the drugs. So those are areas that are also opportunities when you think about quality of care and quality measures and access for people, so that we begin to look at and reframe how we provide care and from the cost of cancer. So that if I can't go to the health system and say, you gave me awful care, I want my money back. regardless, that billing code will go through and the company will get paid. So just thinking of it from an action item to say, how do we look at this so that if a person is receiving awful care, how do we say, you know what, do something about this, or I'm not gonna allow that billing code to go through. That will drastically change the impact on our healthcare system, and also the way care is provided, and also the drugs that we receive, because it all boils down to business and cost and money. So we need to reframe and look at us as a consumer, as a patient, and not just a patient, but a consumer first and a patient second. Because regardless if it is Medicaid, if it's Medicare, if it's private insurance, if it's commercial, you have to pay for it at some cost, in some regard, right? So it's never free. So even if it's public assistance, or if it's the most expensive insurance that you're paying for, is being paid for. So if you look at that from the lens of how do we provide the best care, no matter the cost, regardless of the ability to pay, and see us as a consumer and not just a patient, then that may also change the way that we look at the cost of cancer.
Thank you, Cindy. Great points. You know, as you were speaking, I thought a little bit about how our organization is kind of trying to reframe the conversation. And one of the things that we heard loud and clear as we were talking to community is that oftentimes, especially communities of color, feel that the healthcare system has erased them in all matters. And so we need to really understand that and really think about what that looks like, from cost, making sure that as we're caring for our patients, that we see them. Right? We see them as individuals, and we really walk with them through their treatment. So thank you for that. Nora, what kind of health equity challenges do you see in your role as a genetic counselor at Minnesota Oncology?
Hello, everyone. Thank you for having me. Just before I get into my answer to that question, I guess I should describe what a genetic counselor does. A lot of today's audience might not have heard of a genetic counselor or the services we provide. So oftentimes the patients that we see are the ones who've had rare diagnoses, unexpectedly young diagnoses like a breast cancer before age 45, or they have a large family history of various cancers. And so the big reason people see me and see people in my role is that we want to know what's causing these diagnoses. Is there a better way for us to take care of you and treat you? Which often includes ordering genetic testing. Now, the reason I'm focusing in on that is because genetic testing costs money. And I could have 3 patients with the exact same diagnosis, let's say 3 different women, all have breast cancer at age 44. They want to know, should I be doing a bigger surgery because my risk for breast cancer is significantly higher than most women? One of them does not have insurance. One of them has a high deductible. One of them has great insurance with excellent savings accounts. They should not be getting different decisions for that genetic testing. They should all be able to get that genetic testing without worrying about how much it's going to cost them. And that's something that I often deal with every day. Oftentimes in every visit, someone asks me, how much is this going to cost? And I have had patients say, oh, that's not in my budget. We shouldn't be there when we're talking about things like how we're going to treat someone's cancer. Someone shouldn't have to make decisions based on the cost, when really we could prevent them from having a second diagnosis, or we could screen them in the future from other types of cancer, where they don't have to deal with chemo and radiation and things like that. Now, that's one problem from a systemic standpoint, is this just costs money, and it's going to look, and people are going to make decisions based on things like economic disparities. Another big piece of what is a big challenge in genetic counseling is that systemically our referrals are different. So there's been many, many studies where, let's say again, we have 2 women, breast cancer at 44. A white woman is much more likely to be referred to genetic counseling than a Black one. We miss so many women in African American communities because their doctors don't think about referring them when they should. And I like what Bukata said about centering race in that conversation. When we're educating providers, we shouldn't be just reminding them, hey, any women under 45 need to be referred. We need to specify oftentimes that African-American women get missed. So make sure you pay special attention to those patients so we're not missing any of them. And that really goes into the idea of equity rather than equality. So not necessarily just treating every patient the same, but making sure the ones that are systemically disadvantaged, we treat them in a way that brings them up to the level of the ones that are systemically at an advantage.
Thank you. Thank you. Again, it goes back to seeing that patient, making sure we understand their needs and really providing that quality care. So thank you for your input on that. Dr. Trivedi, what kind of health equity challenges do you see oncology patients having? And the second part to that question is, what types of challenges do your BIPOC patients feel comfortable telling you about?
Thanks, Jackie. So I think we've already kind of gone over that oncology is very unique. Our treatments are really expensive. They're time consuming, they're toxic. So things like social support, health literacy, financial resources become really important in treating someone successfully. You asked about challenges. There's some that we don't see, namely implicit bias. I think we've already touched on that before. There's a lot of gray area in cancer care. So a lot of our decisions, our treatment decisions are subjective. So they're very vulnerable to implicit bias. This can be very insidious. We could spend hours and hours talking about the challenges that we do see, insurance problems, transportation, comorbidities, communication. I have a lot of patients who are BIPOC and don't have a reliable phone number for us to call. It makes it very difficult to set up treatments for them. A lot of them are very busy acting as caregivers to other parts of their family. They're taking care of sick relatives when they're dealing with chemotherapy themselves, and that makes it very difficult. We have language barriers, especially in our Hmong population here. And you can imagine in oncology, there's lots of very difficult, complicated discussions that have to happen. And doing that in a language that isn't your first language is extremely stressful and scary, honestly. And doing it through a virtual translator or somebody over speakerphone is definitely not ideal. Things like reliable housing is very important. I have a patient who's missed multiple chemotherapies, chemotherapy treatments because his bathroom flooded twice, and he missed his treatments. And then I think a big one, which I think a couple people have touched on, is mistrust in the medical community. So we have a very bad history in America of basically all of our systems poorly treating Black Americans. And I think that becomes very challenging, especially when we have to talk to a patient about palliative care and hospice. So not giving treatment to somebody, but actually withholding it, and that's the best thing for them. And we see that very commonly, that those discussions are much more difficult in our BIPOC communities. And it's because of that underlying mistrust from systemic racism that it makes it very difficult. It takes extra time and patience to do that, and not everybody takes it. So I think those are really the challenges, just a couple. We could spend all day talking about it, but just a couple that we see in clinic.
Yeah. Thank you. And again, as we think about this conversation today, is raising the awareness, but also as we begin to understand our patient populations, how do we meet them where they are? So thank you for that. So as we think about, again, going back to Anthony, as you think about professionally, what types of challenges do you see around these social determinants of health?
Great question. I was fortunate enough to just recently graduate from Humphrey School of Public Affairs, and in that I was doing a lot of work regarding research in the health equity space, and there's not a lot of research even out there, to be brutally honest. Now disparities there's a lot of data out there on disparities, but not health equity or specifically equity. And as Nora said, like when we talk about equity, even defining what that is presents a challenge. And across the sector in general, like it's turned into a partisan conversation, and it's a human problem, not a political problem. It's a human rights issue. And so when we talk about the social determinants, like we have to go back historically and look at how systems were created for a specific demographic. And that's not us pointing fingers, that's just saying the reality. When these systems, these social service systems were originally created, human service systems were originally created, they were created for a white individual, a European individual. And so they didn't take into consideration the challenges that people of color had faced. And so if you eliminate trauma from the equation, well, services will look a lot different. But if you add trauma in at that point, I think we would come to an agreement that there needs to be some adjustments regarding how care is given to those people who are facing these social determinants. I had a donor ask me, like, when are you nonprofits going to get on the same page? And it's an easy statement to make, but the reality of it is, usually people give to situations that have impacted them. And if the majority of your donors happen to be white, or they're going to give to entities that they have experience with, who they have some history with, right? In contrast to now, we're trying to communicate to donors specifically, hey, you know what? These communities of color or these BIPOC communities have some challenges. It's almost like we have to convince them that there's an extra reason to give. And so it's not simply bringing them along, it's clearly articulating what's the value add by helping these communities of color find equity. And that makes it a lot more challenging. It takes a lot more tact, skill set, a lot more benevolence from the donors, an extra level of grace. And so while we're still arguing regarding what equity is, and even that social determinants exist, people are still dying, people are still suffering, which makes it even more frustrating. And so these conversations are happening across the board. And, even having this discussion today is a step forward. I think everybody here on the panel is gracious that this conversation is happening. But this is the first step, which is very important on one hand. But on the other hand, it's not as important because there are so many other steps that have to happen after this. So social determinants are large, but we have to agree on definitions regarding what those determinants even are for us to being able to engage and attack them. Social determinants are real, but we can't make it a political issue. It has to be a human rights issue. And I think the good thing about today is that's what we're doing. We're making it a norm, that this conversation is norm. And eventually, hopefully, we'll have people who are being oppressed by these systems have their voice at the table so that we can actually make some strides forward.
Thank you for that. So many great points there as I think about understanding the role that language plays to make sure everyone understands and has the same definitions. As we think about social determinants of health, there are many, but how do we prioritize them? And then as you think about donors and getting the support, the financial support, how do you make this meaningful to those individuals? What's in it for them? Critical conversations to have. Thank you. Bukata, how does culture impact the relationship between provider and patient? And can you provide us with some examples?
Yeah, for sure. So I think one of the things is we talk about social determinants as we center race, as we talk about sort of, and many of our listeners may have heard the term culturally competent, culturally responsive, this idea of culturally concordant care, meaning like representation matters, right? So that does matter as we sort of get into a relationship with a practitioner or a provider. So there's a couple of things that I'll say. One, like the work around sort of culturally responsive, culturally concordant engagements has been happening for a while. In particular, if we take a look in education, right? How do we get more teachers of color has been a rallying cry within education for a long time. And there's research to speak to it as well. So there was recently, a couple of years ago, a study done by the National Bureau of Economic Research about the impact of a single Black teacher on Black students, right? And they found that like randomly assign Black students to a Black teacher, like it dropped, it decreased the dropout rate by a third. It increased high school graduation by like 5% and increased college attainment by like 7%. As compared to those who didn't have a Black teacher. So that's randomly assigned. right? And so this idea of clearly the impacts are there. And then also if we take the work of Dr. Rachel Hardiman and Black maternity and the impacts of having a Black woman doctor engaging with Black women during the birthing process and how that reduced, right, the disparity between Black mothers vis-a-vis white mothers. And one of the things that Dr. Hardiman's research and other research has found is that Black women weren't even being provided the same interventions to save life during that process. And so to some of the points that's been made already, like how do we sort of provide equitable care that as we are engaging with Black mothers that we know die at a rate of 3 to almost 4 times more than their white mother counterparts, how do we sort of make sure we're asking the right questions, seeking the right interventions to decrease that disparity? And so those would be a couple of examples of representation matters, culturally concordant care does have these benefits for both us as providers and also us as patients. And so I think it's important that we continue in our sector to do that work that I know in many other sectors has been sort of happening for a while, varied results, but happening for a while. I think we have to become much more focused in on representation of our providers because we know our patient populations, in particular here in Minnesota, are continually to grow more diverse.
Thank you. Yeah, as we understand kind of where we are as it relates to Minneapolis, St. Paul, some of the challenges that we face is really recruiting those providers of color, right? Unless you're from the Midwest or you have connections here, it's really hard to get those specialty physicians to come. But other organizations have done it, so we need to learn from them. And you made another clear point when we talk about making connections. It's so important that when that patient walks in the room or that patient is on the phone, they immediately feel like they belong here. And we have some ways to go in that. So thank you for those comments. Cindy, personally, what types of challenges have you experienced around cancer health equity?
So I'll start with myself first. I was diagnosed with a rare form of soft tissue cancer that I had been advocating to get treated for at least 10 years. And the majority of my providers are of non-Euro-dominant culture. And the thing that was most frustrating for me is I'm trying to figure out where to start because it's so much. So I felt I had okay, let me just go back. I had a rare form of soft tissue cancer that was found in my breast. And because it was not, I didn't meet the criteria for age. I had no history of breast cancer in my family. I was under 40. Women of African descent traditionally, if I'm not mistaken, have dense breasts. So I kept being ignored and I wasn't heard for years. Thankfully, I was able to eventually have children because I was told I couldn't have children. Thankfully, I was able to have children. And because of that, I was able to say, this is not dense breasts. This is not clogged milk ducts. I've been feeling this growing in my body for the past several years, and I need you to do something about it. I still was ignored because I wasn't 40 years old. So I had a provider who was of African descent at a health system in the Twin Cities who told me that she was not going to argue with me, that she was a provider, and that I needed to listen to her. And I told her, you may be the provider, but this is my body and I've been dealing with this for a long time. And either we're going to get some proper care, I'm gonna have to go somewhere else. So thankfully, by that time I had turned 40 and I was able to get a mammogram, and my provider sent me to get a mammogram. I was nursing my daughter and I had to stop because I said, this isn't clogged milk duct. I've had 2 kids with the type of cancer that I had. It was a slow growing tumor. It was called a soft tissue sarcoma. So they had never treated this before. They had never heard of it before. Everybody I worked with had to look in the books because they had never heard of it. I was the first person in this particular health system to be diagnosed. I was referred to as a case study and not a person. So I was very frustrated with that by the radiologist. That same provider kept telling me that she was a doctor and that she knew and I didn't. So eventually I kept saying, okay, I felt this growing from a pellet that felt like a rock to about the size of a cherry. And I kept, when they said it was a clogged milk duct, when I was pregnant and nursing, I was pushing, trying to clear it out, but it kept getting bigger. So when you're pregnant, the cancer grows at a faster rate. So I had 2 children within 26 months and I felt that lump grow dramatically. To make a long story short, I did get a biopsy because at the time at that system, they had never seen it before. They had to send my what is it called? The sample to another health system. Thankfully, there was one radiologist who had heard of it and properly diagnosed me. And I was given a lumpectomy. And then I had to get a series of mammograms after that. But that process was so frustrating because 1, I didn't need chemo, I didn't need radiation, so I did not get access to any assistance to help pay for medical bills. I did not get access to resources financially for the other things I was dealing with. No one educated me about the holistic lens of dealing with cancer with night sweats and nutrition. It was just, here's this surgery, see you later. Your margins are clear, bye, right? So there was no, now that you have dealing with this, you still have hot flashes, you still have psychological things you're dealing with. Now, when there's things that's going on in your body, every time there's something you wonder, oh my gosh, do I have cancer again? Because the type of cancer that I had was so rare and impacted less than 1% of the population. Fast forward to 2021, May, there was a diagnosis in my family, and it was an advanced stage of cancer. And I have a background in healthcare, and I was telling the person that they need to go to the doctor. They refused to go to the doctor. Well, thankfully, something happened where they were able, it was triggered, and then they were discovered that they had a advanced stage of cancer that has spread through most of their body. This person is not knowledgeable of the healthcare system in the United States. They're immigrant that is a nationalized citizen from another country. So I have had to inform them of what quality of care looks like and what sub-quality of care looks like. From as simple as getting blood pressures done correctly and taken correctly. Have had to advocate on numerous times and educate the person about how to properly get your blood pressure checked. So then that way, if there is an actual diagnosis of high blood pressure or medications, that the person knows that what they're doing, what that person is doing, how they're taking my blood pressure is incorrectly, and I need you to do that better. The other thing that was very frustrating for me is that because we are less likely to be given proper care, if you are an advocate and you're loud and you speak up for yourself, then you become a difficult patient. And it's not that I'm a difficult patient. Traditionally, current trauma, historical trauma shows that I don't matter. So I am going to advocate for myself and the people who I love and care for, because remember, you're going to get paid regardless. So it should mean that I should still get the care and the service that I need, regardless of the ability to pay, because you're still getting paid. So those are some examples of things that occurred over the last few years into current day, even with insurance denying medication and then approving it and then denying it. So not having a care coordinator or a person that has been with us every step of the way through this transition that we're going through in our new normal in real time, that has been also hard as well. So I think that if we create a holistic lens and a concierge of services when people are dealing with an extreme diagnosis where their whole life is turned upside down, and depending on the type of provider they have in their care team, it can make a huge impact on their diagnosis and treatment down the line. So not having to overwhelm the person as they're navigating the disease, and also having to navigate drugs, doctors, insurance with no help. That's been extremely frustrating. And I'm educated. I work in healthcare, and it's been extremely frustrating and overwhelming for me. So I am thankful to organizations like the Angel Foundation and American Cancer Society who have been a resource and a help. And at the same time, hope that there are people on this webinar today that will be able to help people remove barriers and create more equitable policies that we can make changes and improve outcomes for all people, regardless of ethnicity, and provide quality of care because they're still getting paid.
Wow, Cindy, thank you. You know, as I think about my role in a relatively large healthcare system, one of the things is that we have to have individuals like you share your story. The stories is what really get to the heart of the matter. And, you know, hearing you today, I just think, boy, we would all benefit for understanding and knowing what your journey has been like, and that self-advocacy does not equate to being a difficult patient, and oftentimes being patients of color because of bias. That's how we are seen and not being seen as assertive. Thank you for sharing. Dr. Trivedi, eliminating racial disparities in cancer is a daunting task. Where do we start?
Thanks for that question, Jackie. You and Bukata actually took the words right out of my mouth, and that word is community. So I think gathering data and listening to the community we're serving is really the best first step. The problem that's pressing in one community may not be the same or the biggest issue in another. So I think that's really the most important first step. When we were building this cancer center here at Allina, we wanted to build anti-racism into the foundation of it. And our leadership was very supportive of that. I think you remember last summer, I was sending you a lot of emails when I was a bright-eyed, bushy-tailed fellow, bothering you and Vivian and Nukwang, because I had a lot of ideas on what we can do to help build that into our cancer center. One of those was an evidence-based solution to this problem by changing the way our EMR works and things like that. So I was very excited and was putting a lot of work into that. But I didn't start with that first step of really listening and looking at the data and seeing what our problem was. So when we actually did look at the data and talk to our community, we weren't really treating enough BIPOC patients and those specific types of cancers to make that intervention effective. So we had to kind of go back to square one and say, hey, what are the problems that we're facing? And how do we get these patients with these kinds of cancers who are BIPOC into our clinic? So we kind of had to go back to square one, but it was a humbling experience and taught me a lot. But I think it kind of emphasizes the important first step of really listening and gathering data first before kind of going ahead with the solution.
Great, thank you. Wow, what powerful insights, testimonies, and opportunities to hear from each of you today. And I knew we were going to get into this conversation and run out of time. But first and foremost, I am so thankful to all of you for speaking to us today. The stories and focus you shared helped create a space for us to begin to understand our experiences in our cancer community. I am grateful that you were able to share vulnerability, passion, and leadership. When conversations are shared, it allows us to hear many voices and experiences that individuals are facing. We need to first listen and seek to understand before we can initiate a plan to help address health equity issues. We hope this forum will generate a shared vision for the leaders in the cancer community that will begin to impact health inequities. Equally, we have a call to action for everyone who has attended today. We would like to create a community-wide steering committee that can begin to look at how to implement change in our cancer community. If you are interested in learning more and becoming involved with DE&I Cancer Community Initiatives, please reach out to us in the chat feature with your name and email addresses. Later today, you will receive an email with a survey link. We would love to hear your feedback from today's forum. Again, thank you. Thank you for sharing the space with us today. Please enjoy the rest of your day, and we look forward to being in touch. Thank you.